And we are live. Hello, everyone. I'm Jessper Maquindang. And if you're here to build a stronger team and a more effective company culture, you're in the right place. In each episode, we have guests who share tips, strategies, and insights to help you and your people thrive. And I'm excited for today's guest. Dr. Christopher J. Colombo is a board certified critical care physician, retired United States Army Lieutenant Colonel, and executive and positive psychology coach. Over a 24-year military career, Dr. Christopher Colombo has led ICU teams, research programs, and operational medical units in high-stakes environments. He now works with physicians, scientists, and medtech leaders, navigating the complex transition from technical expert to organizational leader. Through functional mentoring, he integrates operational credibility, positive psychology science, and straight talk coaching to help clinician leaders align identity, values, and performance so they can lead without burning out or losing themselves in the process. Let's welcome Dr. Christopher J. Colombo. Dr. Chris, thank you for joining us today.
Thanks for having me, Jessper. After that introduction, I feel like I should take a nap. It seems like I do more than I do.
Very excited to have you with us. So, very excited for today's topic, and specifically, we're talking about how we promote clinicians for technical brilliance, then blame them when those same skills derail their leadership without ever training them to lead. Such an interesting topic, Dr. Chris. Let's look into the research and statistics into this field. Can you tell me more about what you found?
Yeah, absolutely. This sort of came as a very specific niche within physician burnout, based on my own experience and challenges. And I mean, really, burnout is not a niche problem per se. I mean, 40 to 60% of physicians, even in training, before they've gotten out into the workforce, are reporting at least a symptom of burnout. I mean, and that's from the Mayo Clinic. Shanafelt is probably the most well-known researcher there. But even in survey reports from medscape.com, not the most scientific thing, but people are reporting it. It's higher in some specialties, mine in particular. But it's probably double the rate in the general workforce of, symptoms of unfulfillment, depersonalization, excessive fatigue. And it impacts, performance. And performance in a physician realm is not trivial, right? We're talking about double the rate of medical errors in studies in JAMA and the National Academy of Medicine. Increased turnover. There's a concern for early retirement in the physician workforce and healthcare workforce in general. This isn't even just a physician problem. This extends to any healthcare provider. Patients don't like burnt out providers, and if you're burnt out and you're projecting that's not going to go well. Less productivity, less engagement. It's obviously a problem, and one of the things that I see with it is the tendency to lump it all together, right? Burnout is burnout is burnout, and a lot of the interventions then become one size fits all. Oh, everyone's just tired; they need to recharge and refresh. So here's some yoga classes. Here's a lounge with a massage chair in it and some free drinks, and it'll be fine. And that would suggest that the idea of burnout is new. And, probably the most scary and telling statistics are in the 70s, the American Medical Association did a survey of the workforce of physicians and found 1.5 to 2 times higher suicide rates, elevated substance abuse rates, elevated divorce rates. This isn't new. What's different is the structure of healthcare is very different than it was in the 1970s. The work has always been hard, right? This isn't a job for the faint of heart. It's not a profession that is easy. Even when things go well, people are sick and people die. But what's different, we have a greater loss of autonomy, a greater administrative burden, and productivity pressure. There's values misalignment. People discuss moral injury. The idea that ethically you are bound to do what your profession is pledged to do, but your organization is actively impeding that. And how do you get up and go to work every day that way? And then in this specific instance, a good colleague of mine that I'm partnering with, she's an educational specialist and HR professional who has studied this. She and a couple of physicians got together and did a formal interview-based, kind of theme exploration of why are physician leaders in particular experiencing burnout, and what besides just burnout. And what they found is three main themes in their research. That there was when elevated to leadership, and again, that's the specific part. I think if we attack burnout as one giant thing, we lose the specificity that we pride ourselves on in medicine, right? Diagnosis should come first, and then treatment should be specific to that diagnosis. Why would we would do anything different in burnout is beyond me. So the specificity of physician leaders and why they burn out came down to three main things in their research. It was a loss of identity, meaning that clinical identity that we're so invested in gets diminished or, second shelved when you are a leader primarily. A loss of, peer mentorship and support and mentorship in general. It's easy to find a clinical mentor, right? We joke there's always an attendee or attending out there to help you with a clinical problem, but is there a senior physician leader that has the time and wherewithal to train you and mentor you through leadership development? And then that was the other specific question, was a lack of leadership development formally going into a leadership position. And you mentioned it in the intro, is that in general, physicians, and I found this with tech founders, scientists, people who are engineers, people who are technically excellent, right? They go beyond technically competent to be, the true stars in their field. They get elevated to leadership positions because of that technical expertise. And they're under the impression that expertise and credibility that they had at the bedside, at the bench, in the lab is going to translate to credibility as they lead people in organizations and administrative capacities. And it doesn't. And then that becomes a source of burnout and frustration.
Dr. Chris, these are very insightful perspectives. I was curious, as you were looking through the research, what were your initial reactions as you were looking through them?
I mean, I've been aware. There was a movie about people going to medical school, Gross Anatomy, I think it was called, when in the 80s, and I watched that. And that's one of the speeches that the dean gives the students. Oh, by the way, now that you've all decided to stay, this is the profession you chose. And what struck me about that was something that reached pop culture 40, 50 years ago. It wasn't an unknown. And all of a sudden, we're treating burnout as if it's something that we have never encountered or engaged before in the medical profession. And we are counterintuitively, we're not defining it well in all the research that I've seen. Sometimes the best that the researchers do is ask a self-report of a self-defined burnout. They'll just ask, do you feel burnt out? I've conducted burnout research on graduate medical education trainees. I was a program director for an internal medicine program. And we did a burnout intervention. It was a facilitated discussion group about professionalism. We watched Scrubs. I can't believe I got that published, but sometimes things work out. And we actually used an abbreviated psychological instrument to serially measure every month people's symptoms of burnout. It's called the Maslach Burnout Inventory, and there's a short version that we were able to put on SurveyMonkey and get people to be able to run through 9 questions in about 40 seconds and give us a snapshot as we went. But that was a very specific and defined, broadly accepted, verifiable measure of burnout. And a lot of the research is just, do you feel burnt out? Yes. And that contributes, I think, to this lumper problem, right? You have lumpers and splitters. Burnout is all of these separate things, and there's nothing cohesive about it. Obviously, that's not the case, since we can go back and show behaviors that are obviously signs of burnout all the way in the 70s, the first time anybody measured it. But if you lump it all together as the same thing, you end up with a yoga class and a massage chair and a day off instead of a formal leadership development and a mentoring relationship. And obviously, at that point, the treatment does not fit the disease.
Dr. Chris, these are very insightful points. And I was looking at the research as well, and I wanted to get your thoughts on this. And the first one, when we look at technical brilliance and leadership development, something I found from the Center for Creative Leadership, and they discovered that 85% of healthcare leaders report never receiving formal leadership training before stepping into leadership roles. Dr. Chris, wanted to get your thoughts on that.
I have not seen that, and I am not surprised in the least. I have some other colleagues that have founded a leadership consulting and coaching firm, all levels leadership. And one of their recent posts was about, do we take time from the education of physicians, whether it's undergraduate in medical school or graduate in residency, and can we fit in leadership development on top of everything else that they have to learn to competently practice medicine? And I think that's fits with that statistic, whether it is, a scientist in a lab pursuing their PhD. There is so much to know and learn to be competent, let alone excellent at your craft, that anything outside of that direct is seen as a distraction or a takeaway or what are we going to have to miss in order to get this? And that's not an illegitimate concern, right? If we have great leaders who are lousy clinicians, we've created a new, right? There's no solutions. There's just trade-offs. I don't think that's a great trade-off, but there's got to be something. My personal opinion, yes, I'm biased as a physician. I think one of the main solutions for a lot of the woes of the healthcare sector is increased engagement and leadership by clinicians. I think that HR professionals and accountants and organizational leaders and people outside of the direct clinical realm are absolutely vital to these organizations. They have an expertise that physicians just don't have, nurses don't have. However, the context for all of their decisions in a business or an organization or a healthcare provider, they don't get that. And only a clinician that's been at the bedside and held a patient's hand or their family member's hand in a moment of absolute pain and terror or joy in a cure or a treatment working can understand what that mission truly is. And I think you need both halves of that. And I think there's been a diminishment in effective physician leadership. One of the things that came out in my colleagues' research was some comments from physicians that felt they were an ornament or a trophy to be in the C-suite. The chief medical officer was a clinician to lend the C-suite credibility with all of the clinicians that they were leading in the organization, but not because they actually wanted to hear that chief medical officer or chief nursing officer's input. I mean, that's a problem, right? It's purposely marginalizing the key observer and experiencer of the people that you're leading, rather than embracing it and understanding that we've got to have that extra perspective. It just as I don't know, my brother's an accountant, he runs hospitals. We both bring a completely different thing to healthcare organizations that are both vital. One versus the other is just not, it's not a viable future for healthcare. And I think if that's a necessary component, then you have to have leader development and training and strategic thinking and organizational thinking for physicians. We're not trained to do that at the bedside, right? You don't innovate. If you innovate, that's called unconsented experimentation. That's just not okay, right? Researchers research, researchers innovate. These things are vetted and tested and proven, and then they become the clinical mainstream. And then it's our job at the bedside to institute best practices. Now, we do get the opportunity to institute a best practice in the setting of uncertainty and incomplete information. I think that is a key clinical behavior that translates well to organizational leadership. But the thinking on a population scale versus the level of the single patient that we generally think at, there's a best practice for this, what is it, versus a lot of organizational problems have no off-the-shelf answer. Those are two very different things that physicians need experience in mentoring and coaching in order to get skilled at. I think they're absolutely able to be skilled. I mean, they very bright people, right? Doctors and nurses and PAs and nurse practitioners, fantastic ability to for cognition. So it's not that they're untrainable, it's just we're not doing it, and we're expecting, greatness in the untrained.
Dr. Chris, that's an excellent perspective. And I was also looking at some more research, and I found something from the Joint Commission, which is an accreditation provider for healthcare, and they discovered that 70% to 80% of serious medical errors involve communication breakdowns. Dr. Chris, wanted to get your thoughts on that.
Again, that's not surprising. I've done root cause analysis on, medical errors as a critical care chief and an ICU medical director, and when you get into, well, what do you mean by a communication error? It could be something as simple as putting something in the chart that is an unclear abbreviation, right? That may be the simplest. It could be not having that closed loop where you give an order, you make a treatment recommendation, you provide consultation to another physician, and you think you are saying it clearly, and you think they get it, but they haven't read it back to you so that you receive back what you sent out and verify that you did. We teach that specific skill of closed loop communication in cardiac arrest scenarios when you're running a resuscitation on somebody whose heart has stopped and you're trying to restart it. I say that, this is the dose of this medication, and somebody says, okay, you want me to give this dose of this medication? Yes. And I've had mistakes at 3:00 in the morning parroted back to me where, you're in hour 12 of a 16-hour shift and you say something completely wrong because you're trying to do too many things at once. And I work in the ICU because there's great nurses, and hey, did you mean this? Did I just say that? Yeah. No, thank you. And even just that quick skill of the second layer of communication prevents so many of those errors. Now, how do you do that electronically? Right? With the advent of EMRs, if I click the wrong box, is there a closed loop opportunity if that other human on the other end doesn't see it, recognizes an error, and call me back? Or if they've sent an asynchronous communication, there's these secure chats in a lot of the charts. Am I going to get that fast enough that I see it? Not if I'm not directly logged into the chart. So we think we've fixed some communication issues, and we have, right? I can't put in a dangerous abbreviation in most EMRs. It catches me, right? It's a great use of computers and AI, right? I simply can't do it. It will not let me input this. It gives me a pick list of safe abbreviations. Perfect. Secure chats back and forth that you don't know if the other person received it. Did they understand it? You're typing. I'm surprised it's that low, actually, that the communication issues is that low, frankly.
Oh, very interesting. And Dr. Chris, that is an excellent perspective. And I do want to share one more piece of research, but before we do, was there additional research or data that you wanted to share?
No, I think that's as far as stating the problem, I think we've got it. Question is what to do about it.
One more piece of research. This comes from Tricia James, Alice Nayak, and other researchers, and they published in the National Library of Medicine, and they discovered, and this goes back to burnout, leadership training reduced clinician burnout from 47% to 13% among participants. Wanted to get your thoughts on that.
I think that holds up. If you think about how difficult medicine is in general, right? This is the population you're dealing with, the doctors and nurses who sign up for this on purpose. You have to get through high school well enough to get into college and a pre-med program. You have to do well enough in your pre-med or pre-nursing program to get to your clinical training in med school, nursing school. You have then to get to your residency or get through your orientation as a nurse, and you're trained and you're vetted and feedbacked, and you get to be an expert. And that's how you get through doing something that is really difficult and really trying on the human soul. As we go all the way back to the 70s, the job's always been hard. And people were obviously expressing stress and maladaptive behaviors in many cases, but they were still doing the job. There wasn't a physician population crisis because of early retirement. That wasn't something that people said 50 years ago. Well, here's a hypothesis. If you're good at something, even if it's difficult, you'll find fulfillment in the expertise matching the challenge. And I think we can see that broadly across realms that require, response to daily challenge, whether it's athletics, whether it's research and innovation, running a business, being a physician or a nurse. I don't think that's a surprise. And if you put somebody in a position where they're clearly not trained and not an expert, and worse, they have the illusion that they should be, they're going to be burnout. They're going to fail. They're going to quit. And if you train them and that response goes down and they don't feel burnout and they don't quit and they excel, I would be surprised by anyone who's surprised by that research.
Dr. Chris, excellent perspective. And now let's take a deeper dive. And what I'd love to learn more about your story, Dr. Chris, and what gave you the inspiration to really jump into the field of understanding the difference between technical brilliance and that leadership capability. Love to learn more about that.
It's just selfish self-interest through a time machine. I wish I had this kind of perspective and expertise when I was failing as a leader. I became a program director of an internal medicine program, and it went badly. And I had even in the Army, I did have a lot of leadership training and expertise and mentorship. It may not have been the best mentorship in retrospect. It may not have been the most effective leadership training in retrospect. There were a lot of things about me that contributed to my own burnout and my own poor performance in a leadership role that got me removed from the position. And looking back on that, and after I retired from the military, missing the mentoring and development aspect in my junior officers and physicians is what brought me back to coaching. A dear friend that I shared an office with for the last couple of years, we were both in uniform, got into coaching and got me, plugged in with it as a way to bring that aspect back to my post-military career. And most of what I write on my blog and in thought leadership pieces is based on my own experience. So I'm not making this stuff up. I experienced the fish out of water, being over my head in a leadership role, even one that I had, on paper probably been prepared for. We're kidding ourselves with the depth and the specificity that we think we're giving physicians in terms of their leadership roles. And the reason I went into executive coaching and positive psychology coaching is, again, most of my trials and tribulations were in that overlap area of this is going well in my personal life, but the comparable skill and domain in my professional life is a mess, or vice versa. And the light bulb went on of you are you in both places. The idea of this is my work me and this is my personal me is one of those category errors that we make to try to keep things organized. You are you. So being, educated and prepared to help, other physicians, other tech expert leaders to manage both domains and see where the overlap is and make sure that you're looking in the mirror first when you're trying to find a problem and a solution is really kind of my response in the future to things that I can't change in the past.
Dr. Chris, thank you for sharing your story. And as we take a deeper dive into the topic, and again, we tend to promote clinicians for technical brilliance, then blame them when those same skills derail their leadership without ever training them to lead. And as we take a deeper dive, you did cover a lot of it earlier, but I was curious to learn more. Why should people pay more attention to this?
Because I think we lose people that could otherwise have a great impact. And again, I go back to my story. I was a tremendous faculty member in the training program. I received training awards, mentored people on national level award-winning research, and started our mentoring program and was a very sought after mentor. And all of that technical expertise is probably what got me elevated to being a director of the entire program. And The administrative skills were not my cup of tea. The specific mentoring that I continue to do of people that I mentored for 2 years, I'm like, well, I have to finish out. I can't abandon them because I have this new job. That was seen as favoritism, because I was in a leadership role and I was paying more attention to some of my direct reports than others. Well, there's a good reason for that. And the problem is perception is reality. And not explaining myself ahead of time to people just put me in that position of people perceiving me one way. And then, my go-to is to defend myself, which is another thing. It doesn't go well as a leader of an organization to be seen as defensive. And it just snowballed from there. So, being removed from that career aspirational position now removes somebody who is an excellent teacher, an excellent researcher. I had been spearheading a lot of faculty development for that program and building that culture and that milieu of turning other faculty members into what I saw as, this is what I've been awarded for and rewarded for. This is what the standard and the aspiration should be. I'm out of that job, so there goes that expertise and experience to go do something else. I had to rebuild my career and reputation, and I did so. I pivoted to be a department chief for virtual health and telecritical care, and focused more on the research that I was able to do, and still had some faculty role. They loved the tough love approach for some of the residents who were struggling. The straight, as you put it, the straight talk. I tell my patients a lot of times, you're going to thank or accuse me of being a straight shooter at some point in our relationship. That was still seen as valuable in the trenches with poor performing test takers. It just wasn't okay in the figurehead to be that blunt and to be that straight talk and to, hey, this is what it is. Nobody wanted that in that job. They certainly wanted that skill in their armamentarium, but they didn't want that being the main tool in the toolbox for their leader and their boss. And I didn't understand that was a perfectly reasonable expectation, that you needed more tools in the toolbox to lead others of many different personalities and temperaments than the couple of tools that you were great at using that got you there. And realized that through a, as I say, a cognitive frying pan to the head from my partner in this, is a former Army physician himself, Paul Michaud, who got very far into the hospital executive and leadership track before he had to make a change and become a civilian and focus on other things in his life. But he said to me, you are constantly justifying yourself when someone disagrees with you. You are very my way or the highway. He said, I want you to sit and think with something. He said, do you want to be right or do you want to be effective? And that opened up the door for me of, okay, it's not me convincing the person I'm trying to motivate and inspire that my way is right and they should follow it. It's, I have a place that I want to help this person get to, and whatever tool that I can use that's going to resonate with them is effective, and that actually is the right one, even if it's not mine or my first choice. And that was revelatory and very useful in the research and leadership roles that I took on, especially as the pandemic hit, because that was a much more high stakes experience and environment than, how's this person going to do on this rotation in their internal medicine residency, or how is this person going to do on their board exam? They fail their exam, they can take it again. They can take a prep course. If you screw up the pandemic, right, and your technology research and the clinical trials that my wife and I co-led at our hospital, that has repercussions globally, right? You have to have that entire community of people doing the research and innovation to respond to the pandemic, doing it well and leading their teams well, because, the other revelation is how enjoyable it is to not be the smartest person in the room versus how vital it is to try to convince everybody that you are the smartest person in the room. And one of those, I'll leave it to you to figure it out. One of those is not only compatible with leadership, it is ideal. And another one is incompatible with being an effective leader over the long term. I've learned in tech research with people doing machine learning and robotics and putting together all kinds of technology to answer our telecritical care problem and gap during the pandemic, or virologists and pharmacologists coming together to come up with a list of candidate medications that we could put through clinical trials. I used to be glad that I was on mute. I'd be on calls with my wife with the National Institutes of Health saying, how did we end up with this group of folks? I mean, this is like a postgraduate curriculum that we're, experientially in. And then that role of, you have something to contribute. You are a smart person. You are not the smartest person in the room for everything that's going to be said in that room. But that's refreshing, right? It keeps you motivated because now you're learning things. And it also, paradoxically, makes you speak with more authority and more confidence when you know that you are the smartest person in the room on this particular aspect. And people believe you more. You have better credibility when you take that approach instead of trying to be the smartest person about everything all the time. So that's hope that answered your question. It's kind of been some of the experiences that helped me go from struggling leader to now a guy that helps develop and train them formally.
Dr. Chris, those are excellent insights. And as we're taking a deeper dive, I wanted to get more of your perspective. And what do you believe are the biggest leadership gaps you see when clinicians step into leadership roles for the first time?
So, interestingly enough, these are things that folks think they're good at, and they are not. And one of the practical things that turns out people aren't great at is giving feedback. Right? So the goal of feedback, obviously, is to improve someone's performance. And we have the feedback sandwich, right? I tell you something good. I tell you something that's bad. I tell you something else that's good. Most people can't hold three thoughts in their head at the same time. They hear the two good things and forget the thing they're supposed to change. And or they feel bad when after they get this feedback sandwich a few times, they now know that something bad is coming. And you're probably just making up the two good things to cushion the bad thing. So they don't even listen to those either. And it just becomes an opportunity for stress and defensiveness. And then even when folks learn a good feedback method where, okay, the one I use is called plus delta, right? We establish the facts so we both agree on what happened before we start analyzing what you should keep and what you should change. And then it's collaborative. The person receiving feedback goes first. What would you do the same way the same time, the next time? And then as the mentor or the leader, you'd say, okay, I see that. And I would add that you should continue to do this, this, and this. You want people to be good, not lucky. So that you have to identify what they're doing well. And then you ask them, what would you change? What would you do differently? You add to that, validate it, something else. And then at the end say, okay, what are we going to focus on moving forward? We need a path forward. What do you want to pick to work on? And then what do you need resources wise? Is it a coach? Is it a knowledge? Is it practice? Is it an opportunity? So they leave with a plan. Even when you do that, if you haven't done the underlying foundational piece of providing for psychological safety, where you're predictable in your behavior, this person knows that you care and that you are competent in your job and in your role to give them the feedback in the first place. If you haven't demonstrated those, then all of the perfectly constructed and delivered feedback in the world is going to fail to provide that forward motion for that person. And probably the biggest challenge that I see is your psychological safety as a physician in the environment you're in is built on a day-to-day basis over the course of years in the clinical realm. You're competent. By your behavior, you can demonstrate that you care about your nurses and your patients. People see that. And there's a lot of grace given in good relationships. Right? My partner's fond of saying, if the relationship's right, you can say anything. And if the relationship isn't right, there isn't much that you can say. So we go into these leadership roles thinking we have that psychological safety milieu built with a bunch of strangers that have never seen those behaviors. And they have their own perceptions of clinicians and their own hang-ups and their own biases. Okay. Those are real, even if they're not fair. You have to learn to deal with them. And when you go into a situation where you expect everybody extends to you the grace of a good relationship and psychological safety because the last domain that you worked in had it, but you haven't built it in this one, and you just rush into giving feedback and telling people how to do things better and expect that they're going to tell you the truth when you ask for feedback, you're skipping steps. And in general, I usually start one layer below that with people's language. You'll say things, I call it the 7 dirty words. It's just, if you think about it in your own speech, how many times today have you had a thought or said a sentence with should, always, never, just, only, must, except? And if you think of those, and then how fruitful and useful were those thoughts versus how much did they keep you stuck instead of helping you get forward? If you're using them in your self-talk, you probably think that it's okay to use them in speaking to others and your team. These are very difficult to get around when you're trying to build psychological safety and be clear in your expectations, and that you want people to be clear in the feedback to you. So I typically start with helping people clean up their own cognitive traps. Then they feel like they shouldn't have to, and there's the should, right? There's that shouldy thinking. You may not think it's fair that you have to go through intentional behavior to build psychological safety with a new team. You do. You just do. And whether you should or you shouldn't is irrelevant, you do. And once you go through your own cognitive trap, clean out, build some psychological safety with your team, and learn a good method for delivering feedback and receiving it, all of a sudden, right, you become a much more effective leader because you've built the thing that we're generally feeling, which is trust. People trust you at the bedside. They don't trust you at the head of that conference table.
Dr. Chris, those are excellent points. And this gap in leadership, how does it affect patient outcomes?
Well, I think it's on a bigger strategic scale. If you don't have that physician and nurse and provider perspective appropriately represented in the approach to problems and problem solving, I mean, we have a healthcare system that a lot of people would objectively look and say, is it really serving the needs of the end user, the patient, right? And even if we say, okay, well, the patient is not healthcare's customer, the patient is the doctor and nurse's customer. The healthcare system has the doctor and nurse as the customer. Okay. That strengthens my argument. You should absolutely have customer representation in your strategic thinking. And if you don't, I don't think you can be surprised when the systems themselves don't seem to be designed for patients. And then even just more specifically, if I take a competent, excellent clinician out of their clinical role and they are elevated to a leadership role that they then burn out, and they go and become a consultant or get out of medicine entirely, which we saw a lot of in following the pandemic, right? We had a stressed healthcare system that wasn't built for it. And our providers took the brunt of that. And many of them said, okay, I'm done now. And we're still managing the nursing shortage. We're still trying to figure out how to get people into medicine and get them to stay there. And this is absolutely a domain where if you don't have the providers and expertise, you're going to have worse patient outcomes. You're removing that, and the downstream effects of now, how do I mentor my new clinicians if my older clinicians have either retired or they're quiet quitting and they're not engaged? We have been taking for granted how a profession self-perpetuates. right? It is one of the definitions of a profession, right? Professions are high stakes, they are self-regulated, and they involve a high level of trust, right? So the usual archetypes that are thrown out are, military, healthcare, and clergy. And all of those, the profession of arms, religion, and healthcare, the people that are practitioners are the ones who train and develop the next and decide who's in and who's out, right? Physicians are still primarily deciding who goes to medical school on admissions committees. Okay. If you have disengaged people deciding who comes in or who comes out, are you certain that the quality that you take for granted in naming something a profession is going to be upheld? I don't see how you could. So I think the degrading of a profession is its own problem, since it's supposed to be a self-sustaining culture.
Dr. Chris, those are excellent insights. And as we're taking a deeper dive, how can our healthcare system better prepare clinicians to take on leadership?
I think the immediate, kind of tactical approach is identify who wants to be a leader and then train them for it before they get to the position. And, I think formal, and I think there's some people that are reticent to pursue a leadership position because they might be good at it, but they know they're not going to be good at it without training, and they don't want to set themselves up for frustration and failure. So I think we potentially increase the pool of people who would be good at it and would embrace that training wholeheartedly and then be skilled at it by just being upfront and dispelling this myth that because you are a great clinician, and I think this extends, as I said, to, it was me as a faculty, because you're a great faculty, you're going to make a great leader of faculty. And, I'm an N of one, but I can assure you that didn't happen, right? Because you're a great scientist and engineer, you're going to be absolutely well suited to found your own company and lead it to glory. And there are so many great technological advances that are on the business scrap heap because the founder was not competent to run their own organization. And many great tech stories of the founder realizing that and getting a board of directors and a C-suite of people who are competent at running the business, and those people recognizing, I'm not doing tech development, I'm helping get this genius's work out into the world. I think dispelling that myth and then just being honest about it, right? Reality is undefeated. So just embrace it. You're not trained for this. I want to do that thing. Okay, well then let's get you trained.
Dr. Riss, those are excellent points. And let's talk about staying the course and status quo. Now, if we continue promoting technical experts without leadership development, what do you believe healthcare leadership will look like 10 years from now?
I mean, I think people have difficulty seeing that it would potentially degrade more than now. Everybody wonders, well, this is terrible, but could it get any worse? Yes, I think it could. And I think the downstream effects are not just within the leadership suite of still, getting folks that are competent and then elevated and then frustrated and burnout and disengaged. I think that potentially has downstream effects for training clinicians in the first place, right? If you say, hey, I want to go into healthcare, people really stop and they say, why? What's the draw? It's a mess. And I think that's, if you scare away the best and the brightest from a profession that is one of the oldest in civilization, right? Cultures have medicine shamans and medicine men, and that's been a thing because sickness and illness and injury is something that we know is bad and we put our resources to, and we've been developing that. Or do you really want that downstream effect to then start not only affecting leadership, but really to be affecting the clinical milieu? We're seeing it in nursing. I can't come up with a logical reason why physicians would be immune from the same, de-evolution in the profession. And if that's not the canary in the coal mine, I don't know what is.
Dr. Chris, those are excellent perspectives. Now, in finding a solution and in developing one, if you could redesign the way clinicians do become leaders, what would you do differently?
And well, this might seem like a shameless plug, but it's not just me. It's the colleagues that I've networked with. We all have our different approaches. I mean, mine is I've been developing what I call the imposter to impact, kind of a 30-day nuts and bolts. Here's the stuff you didn't know that you didn't know, but you're absolutely capable of learning in, a set of quick, video course pieces and exercises that you go through, and knowing that that's not enough, right? I'm a fan of the 80% solution, right? So that's sort of my 80% solution is like, okay, if this solves most of your problems, just do it. And then later, when you have specific problems that are way outside of that 80%, and knowing that, the Pareto principle of, okay, it's 20% of that knowledge, it's going to get me 80% of the bang for my buck. That's how I've designed my curriculum. And also as a trigger for add-on, I'm developing a 90-day group coaching for physician leaders, so that there is a little bit of a hive mind in helping people see different perspectives to solve what are their individual problems that's not covered by the 80%. And then still, doing a deeper dive on that 80% solution. I've partnered with Helix MD, and they have a completely different approach for a different set of problems. They're focused more on the leaders that have been good at it. They were trained, they were competent, or they figured it out on the job, and they're getting to that later part of their career where they're like, I'm good at this, everybody thinks so, and I am unfulfilled entirely. That's more of a meaning and values problem than a nuts and bolts leadership skills problem. So they have a curriculum developed for that, and coaches to go with it to help, digest and help people think through. And then I have other colleagues that, try to do a range of these things, but most of what the community that I frequent, the fellow travelers in the physician coaching and leader development space, we're trying to make the treatment fit the diagnosis. So are you burnt out because you have your own cognitive traps, you don't know how to make your team trust you, and you give feedback that makes people mad and defensive, and then your team breaks down, and you can't even get to how do we strategically innovate and solve a problem? Which I also have an approach to that I've developed from teaching clinicians how to do medical care in austere environments, because that is one situation where now you have to innovate because everything that you knew as a best practice isn't available. So you can't go from best to nothing. You've got to have in between minimum, better, best, and think in that framework. So that light bulb went on, and that translated well to how do you solve problems that don't have best practice answers when they're out of your realm. And the idea of you're not the smartest person in the room, but you need to assemble the smartest people in the building to get in your room and want them to be there. So I take a nuts and bolts approach for the people that had the problem that I had, which was I was great at something, and focusing on just using the tools that I was great at, it caused me to self-destruct. And I have other colleagues that are focusing on the other end of the spectrum, which is, okay, what if you are great and you're still burnt out? That's it. I give people, hey, you're going to build trust and psychological safety, and here's how to give feedback properly. And they're looking at me like, what does that have to do with my problem? And I think that's sort of a larger statement on how burnout has been approached by healthcare organizations. I mean, again, the joke that I constantly make is, does this organization have a burnout problem? Yes. How can you tell? There's a physician lounge with, a fridge that has free bottled water and a massage chair and coloring books. I do not begrudge anyone their coloring books. All right. My wife is a physician. We went on a trip, and my gift to her was a small watercolor set, because art is absolutely therapeutic. And if you are burnt out because your organization puts you in a position where moral injury is your daily bread, All the watercolor in the world is not going to help that. And if you are burnt out because your team won't listen to you and you can't figure out how to make them listen to you, and now you can't solve problems for those clinicians that you are leading that are telling you the organization's failing us and we have moral injury because of it, I don't see a massage chair being the solution to that. And what I want to ask hospital administrators and leaders is, okay, you had a burnout problem. Yeah, we identified it. And so you came up with this lounge and these restorative practices. Yes. How's your burnout problem now? If they've bothered to measure, they generally don't see much effect. And most of the time they're like, why would we measure that? We fixed it. So that's not how we practice medicine, right? I have a level of uncertainty. I think I know what's going on. So here's my proposed intervention. I write orders, people execute that intervention, and then I check to see if it worked, right? I constantly reassess to see, okay, was I right? And how do I know? Well, the thing I proposed to do about the thing that I thought was there worked and got better. Pretty decent indication that you were on the right track. It didn't work. Okay. Either I did the wrong thing. I didn't do enough of the right thing. I have the wrong idea entirely about what's going on. Let me measure more and figure that out. That loop is intuitive to physicians at the bedside. It's one of the reasons I put it at the heart of my strategic thinking curriculum. And I think that's the way out, is stopping the idea of burnout being a wastebasket term for every expression of dissatisfaction, depersonalization, and fatigue. There's reasons for that, and they have to be individualized. If somebody is struggling with their relationship at home or with depression or with a medical diagnosis, we'll just take another day off. Or how about we treat that thing and see how much we can improve this person's performance and life and satisfaction and flourishing. And I think it's the same thing on the organizational level. When you have a intervention that does not fit what the problem is, and you haven't even bothered to specifically measure the problem, and you're so sure you're right, you don't measure it and follow up after your intervention, I don't see that as a viable approach. So that's why my colleagues and I, we've pledged to do things differently.
Dr. Chris, those are excellent perspectives. And as we wrap up today's incredible conversation, could you tell us more about how people can reach you, should they want to learn more about you and the work you do?
Absolutely. So my blog and home website is functionalmentoring.com, all one word spelled as it is. You see it right below my name there. We're developing Functional Mentoring Academy, which is where we're going to do our training courses in positive psychology, as well as in physician leader development and physician leader workshops. We offer individual coaching. And again, I'm a fan of, ask the question, if it's not me or if it's someone else, do you need individual coaching, or are you a pretty smart person and you can pursue your 80% solution to work out most of your bugs, and then, go through with the investment and the time that it would take for individual coaching to do the things that require that. I think a lot of people are willing to take somebody who's burning out, charge them an excessive amount of money for individual coaching, when honestly, it could be an asynchronous training course that they can avail themselves of. And again, read my blog. If you like my thought leadership, by all means, subscribe. I publish every couple of weeks because I'm a fan of long form, and these pieces kind of tackle a little bit bigger pieces, or I'll break burnout into, I think the third installment is on tap for this week, and then I have a fourth final installment that'll come out in a couple of weeks. It's long form, takes a little bit of time to digest, but that's me. And if that's your cup of tea, by all means, I'd love to work with you and talk with you further. And if I'm not your cup of tea, come by the website anyway and reach out to me. I know so many people in this space of so many different temperaments. Most of us that are colleagues and friends, everybody wonders, how are you two friends? Doesn't matter. We're committed to the same, profession. And that's one of the ways that we maintain a relationship. And we're modeling that idea of you can be very different and still be on each other's team. And, if I'm not your cup of tea, I can help you find someone that is. But for goodness sake, if you're burnt out, and whether you're a physician or not, a lot of this translates across industries. Reach out, find someone who is your cup of tea, find some resource that is your 80% solution so that you can start to acquire those skills and that you can figure out if you do need any other individual. And if it's not a skills problem, what is the why behind your burnout? Don't just accept that burnout is this wastebasket term that we get to throw around. Come to functionalmentoring.com, reach out to me. You can contact me on that site. Find me on YouTube, LinkedIn, Facebook. And again, if it's not me, I will not take it personally. I just want you to get connected with somebody that can help you.
And Dr. Chris, before we go, what is your final piece of wisdom for our audience?
I will offer the same thing that my partner offered to me that again, I refer to as my cognitive frying pan. Just ask yourself, when you are insisting that you're the smartest person in the room and that you know everything or that this is the way to go, do you want to be right or do you want to be effective? If you can be both, great. But if you had to choose winning that argument or achieving your mission, which do you want to be? Which do you want to do?
Dr. Chris, excellent piece of wisdom. And for everyone out there, please feel free to share this conversation with leaders who could benefit from this. And Dr. Chris, thank you again for today's conversation. So many valuable insights.
I really appreciate you having me on.
Absolutely. I just want to say thank you for sharing your perspectives on burnout, this large gap between technical brilliance and leadership capability, and what we can do for our healthcare system to really create better leaders. So again, thank you, Dr. Chris. Very insightful conversation today.
Thanks again, Jessper. Look forward to talking again in the future.
Absolutely. And to everyone out there, thank you again for tuning in. I'll see you in the next episode.